My specialty is treating the untreatable. I mean, if it works and it never comes back, that's a cure.
Sure.
And that's what gene therapy can do. So we're no longer managing disease. We're actually eradicating it from that person's life forever.
This conversation is getting more and more exciting.
If you're going to allow somebody to elect to kill themselves, why would you allowing them to elect to have a experimental therapy? This is how we will treat people in the future.
How soon you would figure it out? I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 19 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Welcome to Soberhead Podcast. Today's guest is a true pioneer on the front lines of medicine, Dr. Patrick Sewell. With a background in internal medicine, diagnostic radiology, neurointerventional vascular radiology, and interventional oncology, Dr. Sewell has spent decades treating the untreatable, patients with cancers and diseases that others have given up on. In this episode, we dive into his groundbreaking work with stem cells and gene therapy, exploring how he creates personalized treatment for rare diseases, difficult cancers, and even age-related decline. We discuss powerful longevity genes like klotho, PGC1 alpha, and Folistatin, how gene therapy can reverse cognitive decline and muscle loss, and even his latest project, developing one-time gene therapy to dramatically reduce cravings in addiction. If you've ever wondered what the future of medicine looks like, where we no longer just managing disease, but actually curing it, this is an eye-opening conversation you won't want to miss. This episode of Soberhead Podcast is brought to you with the support of Gedik Foundation for Education. For over 30 years, Gedik Foundation has been providing opportunities for youngsters, children, and women to realize their dreams through scholarships, projects, and social work. And we're proud to be on this journey together. Investing in education is investment in the future. Subscribe and support us in our quest to bring you the most current scientific data and continue your access to the world-renowned experts in their fields as guests on Soberhead, with Turkish translation and completely free of charge. Comment on the episodes, like, and share. Dr. Patrick Sewell, welcome to Soberhead Podcast. It's such an honor in person in Istanbul to have you.
Thank you.
I had the chance to listen to you in Cannes at Longevity Docs Summit, and it was super informative. Just to give a little information to our audience, your company, Triple Helix, is focusing on gene therapies.
Correct.
Mostly, at least.
Yes. And some stem cell stuff.
Yes, I was going to add that too, some stem cells as well. Your background comes from?
Internal medicine, diagnostic radiology, neurointerventional vascular radiology, interventional oncology. That was my formal training. And then I pioneered a lot of oncology technology and surgeries and some research in that areas, and then went into private practice. I started with stem cells in 2009, and I started with gene therapy in 2015, roughly. 2015?
Yeah. And since then,
I still have a very robust oncology practice.
Oh, you do?
Having done cutting-edge oncology for 20 years, I have colleagues all over the world, and I guess a presence that people still seek me for. Very difficult. My specialty is treating the untreatable, basically. The impossible cancer treatment is I get those patients. Nobody has anything to do. They don't have anything to offer. They've exhausted all therapies. The patient's still alive, and they want to stay alive, and I have to invent a therapy for them, basically.
And some of these therapies are through gene therapy.
Yes, exactly.
And some others, probably some surgical?
Yep, some surgical. A combination of many things. But that is the essence of how I got into gene therapy. That reason right there. Patients showing up alive, wanting to stay alive, medical science has nothing to offer them, we have an experimental treatment, what we call an N of 1, that we could try. And so through that process, we come up with a treatment unique for them. They're fully aware of the risks and benefits, and they can make a decision whether they want it or not, and I can choose to participate. And so I end up treating patients like that.
And you also told me some moving stories, actually, how you were using the stem cells. Back in the days with people who were going to be amputated.
I'm also wound care hyperbaric certified and a wound care doctor. So I had a group of patients that would come to the wound care center at the hospital I worked at, and they had osteomyelitis, which is infection of the bone in their foot. It's very difficult to eradicate, even with the best antibiotics and even with the hyperbaric chambers. The treatment rate is low, like 50%, the cure rate. And they often end up getting their foot or leg amputated. And it's multifactorial. It's not just the infection, it's the lack of blood supply. So I was rebuilding their blood supply to their leg through a procedure, a surgical procedure, and the tissue doesn't heal without adequate blood and nutrients. So that was part of it. And about the same time in 2009, one of my colleagues started one of the first stem cell corporations in the United States.
Umbilical cord or?
Umbilical cord, exactly. Placenta umbilical cord. And so I was able to acquire some of his pre-commercial material and apply it to these patients who were going to have their foot amputated. And the cure rate went from 50% to 90%. And that was 2009, and that was my first opening to stem cells and what they could do. So then I continued to work with them, and then that and my colleagues around the world who were always doing cutting-edge stuff led me to gene therapy in 2015. And now I do gene therapy, as you know, but I also do gene therapy on stem cells and make super stem cells and use those for certain things now.
Gene therapy on stem cells.
And then I put the stem cells in certain environments, and they do miraculous things that normal stem cells can't do.
All right. I have your website in front of me, and what I see is that you have 3 focuses. One is genetic and rare diseases, one is age-related decline, and the other one, performance enhancement.
Right. And cancer is in there. But cancer practice, I don't like to promote the cancer practice because it's very private and it's not something we want to make public is a big deal. I mean, the oncologists, 99% of my patients are doctor referred. So I don't need to put it on my website.
Can you explain what gene therapy is?
Sure. There's a number of different kinds of gene therapy.
Okay.
For instance, a lot of the listeners may have heard of CAR-T, C-A-R-T, and that's a cancer therapy of the white blood cells, but technically it's a gene therapy. Now, I don't really, when I say gene therapy, I'm not referring to CAR-T, but scientifically that's a gene therapy. Then there's CRISPR, which is another gene therapy that works in a certain way. And then there's gene addition therapy, which is what I do, which works in another way. And they all have their benefits and drawbacks. CRISPR is the most sophisticated and the most powerful, but it's largely unknown and therefore carries a potential for great danger.
How exactly it works?
CRISPR is an enzyme that science discovered where it can literally go in and snip out like scissors part of your chromosome and put in a new gene. And so it integrates into your chromosome. Therefore, it's passed on to your children forever. It's now part of your genes. Whereas gene addition is what I do. I put a gene in the cell, but not on the chromosome. And so for your lifetime, the gene works, but it doesn't get passed to your children. And there's some reasons for that. Not everything that you have wrong with you, they will have. And number 2, it's very safe. We know gene addition therapy with AAV is the backbone of all gene therapies. Almost the majority of FDA-approved gene therapies are gene addition therapies. There's one approved CRISPR therapy. So gene addition therapy has a long track record of safety. We know exactly what it's going to do. We know if it causes cancer or not. We know if it causes mutations or not. We know all about that technology. We don't about CRISPR. So CRISPR is for the future.
And also there's the with-ministerical plasmid.
Plasmid is a very, very simplistic form of gene therapy. With a gene therapy, imagine if you want to treat a certain cell in the body, you have to direct it there. And plasmid doesn't have that ability. Plasmid just flows where the water flows or where the blood flows. And so it can end up in a wrong place and do harm. That's one of the drawbacks. One of the benefits is it's very inexpensive to build. But
they sell for expensive prices.
Yes.
What I heard is they're selling it, let's say, roughly around $20,000, but it costs them like a couple of $100.
Probably $10.
Yeah,
would be my guess.
Exactly.
To manufacture it. Yeah, but I don't know for sure. So, but that's capitalism.
Yeah,
I mean,
of course. I heard that, and I was like, wow, it's buying the peptide almost.
So yeah, well, here's an interesting. The cheapest FDA-approved gene therapy is $2.5 million. The kind I do.
Yeah.
Now, I don't have any gene therapies that are anywhere close to that.
What are these therapies?
They are therapies for rare diseases. Some of them are more common, like sickle cell disease. They're not for aging because the FDA doesn't recognize aging as a disease. So they might be for a muscular dystrophy. One's for muscular dystrophy. One's for sickle cell anemia, inherited genetic diseases. I'll give you my. I don't know this for a fact, but this is what I understand is how they price them. Again, it resembles it's capitalism. So if I'm a pharmaceutical company and I'm selling you a high blood pressure pill, and you're going to buy for 40 years, I'm going to make $4 million off of you for 4 years. 40 years, sorry. Now I invent a gene therapy, so you don't have to buy that pill. What am I going to sell the gene therapy to you for? $4 million. Because why would I sell it for $1 million? I've just lost $3 million.
Right.
I can't confirm that because I don't have it from the pharmaceutical company, but that's the general understanding.
Let's then now start talking how you are applying the genes that you are using.
Yeah. So
it's the AAV.
It's AAV, adeno-associated virus.
Yeah, okay.
It's a virus that doesn't cause any illness or sickness. And in fact, it exists in nature, and many people have been exposed to it and don't even know it because it doesn't make you sick. Because it doesn't make you sick, we can use it as a delivery truck for a gene. So I like to use the DHL truck. The virus is the DHL truck, and the packages in the back of the truck are the genes. So I take the virus's packages out, and I put in the gene I want, which is a package, okay? And I put it in the truck, and I tell the truck to go to your brain. In fact, I tell it to go to a specific part of your brain because there are other ways I could program it, which you can't do with plasmids. This is where the plasmid technology fails. I can make that DHL truck virus go to the front part of your brain on the left side where it's a certain temperature. I mean, very specific, the way you design the gene therapy. And so that means with specificity comes increased result, better results, fewer complications, and lower costs.
So question over here where it's important. How do you measure which part of the brain is malfunctioning? And do you create a specific gene for the specific person?
Yes.
At least for, let's say, for klotho, but a specific style so it goes wherever part.
Yeah. So what you're getting at is, yes, gene therapies are personalized. A good example would be a cancer. Let's say you have pancreatic cancer and your twin sister has pancreatic cancer. Your cancers are going to be different molecularly. So if I build a gene therapy for your cancer and hers, there are going to be different combinations of genes, different dosages, even some you will get that her cancer won't respond to. So most of the gene therapies, all of the disease gene therapies are what we call bespoke or personalized. I sample your tumor and I do a genetic analysis on it, and I know exactly what it's composed of, and then I build a therapy for your cancer and only your cancer. Now, if I'm treating aging, like klotho, then you get the generic klotho gene because it's the same gene everybody has, and it's not malfunctioning, you just need more of it. So it goes both ways. Sometimes it's personalized for diseases, for cancer and for genetic diseases. If you're born with a genetic disease, then you need a specific gene that I can only determine by measuring your body and your DNA. But if it's for just normal aging, then a generic off-the-shelf klotho or Folistatin works.
Okay. How does that gene that you sent in work?
The DHL truck drives up to the cell. And the cell grabs the package out of the truck and takes it to the cytoplasm. It takes it to the nucleus and it opens the package. And inside is a gene. Once it opens the box, the gene starts working. The normal mechanics in the cell that exist already in every cell, they read the gene and they make mRNA. And that goes out into the cytoplasm. And that memory RNA, it makes a protein. And that protein is an enzyme. And that's what you're lacking. So when I put the gene in, it makes the enzyme you're lacking. And it makes it at a certain rate. And I can program how much to make, because sometimes you need a little bit and this person may need more. So it makes it continuously at a certain dose that you need. So we can control a lot of those. We can be very precise with it.
How long they last?
The data on AAV gene therapies shows that right now they last at least 2 decades. We can say, and it's independent of the gene. I mean, it can vary, of course, but in general, an AAV gene therapy, gene addition therapy, published data shows 15 to 20 years right now.
Do you want to start talking a little bit about the specific genes?
Yeah, there's several categories. We're going to concentrate on the aging longevity genes.
Sure.
Because the cancer genes are individual and like we said.
If we're going to spend most time on talking about the longevity and aging, let's then give a little bit of the success stories that you have with the cancer genes, because it's important for people to know who are listening to that.
Oh, yeah, absolutely.
We don't need to get into it because it seems like there's a lot of different ones.
There's several important points I need to make about the gene therapy for cancer. One is it doesn't interfere with other therapies. So it's an additional tool. If you need chemotherapy, you can still get chemotherapy. If you need radiation, you can still get radiation. If you need immunotherapy, you can still get immunotherapy. This is a totally different approach that adds to that armament of things we fight with cancer with. In some cases, the gene therapy is miraculously important. In some cases, it helps generally with the other therapies. And that's really dependent on the stage of the cancer and the type of cancer. And so it's highly variable. But the point is, imagine if we only had chemotherapy to treat cancer right now, as opposed to chemotherapy plus immunotherapy plus radiation plus gene therapy. The more tools you have, the better for cancer.
What does it do?
So cancer is very sneaky. It turns off self-destruct genes. The most well-known is P53 or TP53. TP53 is a gene in all cells, and when a cell senses it's cancerous, it pushes the self-destruct button, which is TP53. Well, what happens is cancer is sneaky, and it disables the self-destruct button before it can be pushed. I can reinstall the self-destruct button through gene therapy.
To the cancer cell.
To the cancer cell. I can reinstall it to a normal cell too, but the normal cell won't push the button. But if I put it back in a cancer cell, to put it in very simplistic terms, the cell pushes the button and kills itself. Or it becomes more susceptible to the chemotherapy, are more sensitive to the radiation as well. It harms, either kills the cancer cell or it weakens it significantly so the other therapies can work. Okay. Yeah, so it's a team player or it's a magic bullet sometimes.
Yeah, I did actually 2 separate podcasts about cancer. One was with a cancer researcher, and she explained how sneaky it is, really.
Super sneaky.
Like, it's so difficult to really find a way to kill it. It creates their own
metabolism,
their own veins.
Yeah.
The
key to there's one takeaway for cancer is cancer is sneaky, and so time is your enemy. If you give it time, it'll find a way around what you're trying to do. So you need to hit it with everything all at once. If you give chemotherapy, then radiation, then gene therapy, that's not nearly as effective as chemo, radiation, gene therapy all at once, because you're hitting multiple weak points. If you just hit one weak point, it survives and adapts.
Then, because there's so many different cancer types, how many of them that you are mostly successful or focusing?
All of the cancer cells turn off these gene suppressors. And I have a list of, I think, close to 200 of them that are cancer suppressor genes that a various cancer will turn off that I can reinstall.
All right.
So that's what I mean by cancer is so sneaky. It literally, we have 200 self-defense mechanism genes and it can turn them all off. if you, given the time. But now we have modern science technology can reinstall them and give us another chance. And I don't know which ones are turned off without sampling the tumor, because your tumor may turn off 115 and 72, and his might turn off 103 and 142. So I have to biopsy the tumor and analyze it, a genetic analysis.
But which ones are you the most successful?
Fortunately, it happens to be the ones that are in large numbers. Colon and lung and breast I can impact highly. Right. Prostate is difficult, mainly because it's bone. It's often bone seated once it gets out of the prostate gland, and penetrating the bone with various therapies is difficult in general because of the nature of bone. But colon cancer, breast cancer, lung cancer, even brain tumors, because we have so little to offer brain tumors. Even the smallest advance is good, and gene therapy can make a dent in that. Pancreatic cancer is a big one.
Wow.
Pancreatic cancer is deadly. But, you know, I've actually have a number of pancreatic cancer that I've cured that should have died.
Amazing.
We're finally making a dent in the really tough cancers.
Oh, that's amazing. I'm so this conversation is getting more and more exciting and very hopeful for people, actually. Now, let's come to the age-related illnesses, longevity and aging. I mean, there are a couple of them that really are killers, like heart disease, Alzheimer's disease, diabetes, and cancer. We spoke already, but these three are really impacting people's life, and I think that there are multiple gene therapies that are really effective.
There are, yeah. So PGC1 alpha and FGF21 are major metabolic manipulator genes. A lot of research supports this, and my early clinical work supports that if you can manipulate those genes in a positive way through gene addition, you can significantly increase the metabolism and increase insulin sensitivity, which means you can make diabetes, type 2 diabetes, and obesity much better, like go away.
You reverse the insulin sensitivity?
Yeah, you reverse the insulin insensitivity, and you increase their metabolism. So they turn from a person who's overweight and has type 2 diabetes or insulin insensitivity to a person who has a more normal metabolism or even a normal metabolism. So they don't have type 2 diabetes, obesity anymore, or they have a very mild case. And that is monumental considering that 80% of the United States is overweight and has type 2 diabetes, you know. And that explains the Ozempic GLP-1 agonist market of $800 billion this year in the United States in sales.
How about type 1 diabetes? Because that's an autoimmune disorder.
Yeah, type 1. So I don't have a cure for type 1 diabetes, but there is a study, I think we're very close. There's a group out of New York that took stem cells and they cured 10 people for a year now with type 1 diabetes. And it's a form of gene therapy. It's not gene addition therapy, but they manipulated the stem cells.
Gene reprogramming?
Reprogrammed them, yeah. And so I think we're not far from type 1 diabetes cure. I think we're close.
Oh, so they are rejuvenating the pancreas.
Basically making a pancreas another part of the body.
Okay.
Making with the insulin producing cells in the liver, or they put them anywhere. They don't have to be in the pancreas as long as they make insulin in the bloodstream. And that's what they managed to do, which is amazing.
It is amazing because people are really...
And 10 patients with sustained, we'll call it a cure, for a year now, ongoing. They haven't taken insulin for a year.
But the costs are super high, I guess, yeah?
The costs are high, but it's like the iPhone. When the iPhone came out, it was very expensive. But
it still is.
It's still, if you get the new model.
Yeah.
Costs come down. Well, I'll give you another example. I made some manufacturing breakthroughs and some design breakthroughs, and I was able to drop my gene therapy costs by 75% compared to 2 years ago. It was simply better science, better manufacturing, and better design. There'll be more of those. As the cost is, the expense is high, but a lot of that is artificial. It's market driven. If I built everything under one building, I could drop the cost tremendously. But my company's not that big yet. But if at one point I'll have my own everything, and I won't have to pay this company to make this part and this company to make that part, because they all charge a profit.
It's in front of me. Let's talk about the age-related decline, sarcopenia, cognitive decline, cardiovascular aging like we spoke, telomere shortening, mitochondrial dysfunction, epigenetic aging. They all use obviously different genes.
Right.
Shall we speak about cognitive decline a little bit? Because people
Sure.
are really struggling with it. It's a painful situation for the patient, obviously, but for their family as well.
Of course, of course. Yeah, so there's what we call normal aging, which we shouldn't call it that because now we can reverse it. But we call it normal aging, which is forgetfulness and poor concentration, and you can't remember where you left your phone, where you left your keys, where you parked your car. It's actually possible to reverse that with klotho gene therapy and a number of gene therapies, but klotho being the big one. We call dementia a disease when actually it's a form of accelerated aging where the normal aging process is just into high gear and there's some unique genetic abnormalities that make it even worse. It also responds to klotho. In other words, normal aging brain and advanced aging brain both occur because of low klotho levels in the brain, among other things, but klotho is one of the most important. So we have a number of animal studies and human studies that show if you could restore klotho levels in the brain, then those mental deficits reverse.
Can you explain what is klotho?
Yeah, so klotho is a gene that makes a protein. It makes 3 proteins. Klotho, when we say klotho, we're speaking of klotho alpha, but there's a klotho beta and there's a klotho gamma, and they do different things. But for practical purposes, and as far as the world knows, klotho means klotho alpha. Klotho alpha does a number of things in the brain. It maintains neural connections. It maintains myelin or insulation on the nerves. It helps the garbage trucks of the brain clean up the garbage. So when klotho levels drop, it's like having the garbage department's gone on strike. And when you have a bunch of garbage build up, you know what happens in the city. Okay, your metabolism suffers, so things aren't delivered on time. All sorts of functional issues come up when the garbage truck goes on strike. When your nerve electrical insulation, myelin, degrades because it's not being repaired every day, then your electrical conductivity slows. So your nerve no longer goes 1,000 miles an hour, it's going 50 miles an hour. And that translates into slower thinking and poor concentration and memory deficits. The other thing that happens in your brain is your mitochondria suffer. As you age, all over your body, your mitochondria suffer. But as you age, your mitochondria become like an old car. They make a lot of pollution, and the engine doesn't run very well. It needs a tune-up. And our body tries to tune it up, but as we age, our repair systems start to suffer. And so klotho and some other genes, when you increase their expression, the repair system kicks in high gear.
I see the BDNF, brain-derived neurotrophic factor enhancement. Is that a different gene?
That's a different gene.
Because that's important. That's
it's
when people
important.
have concussion and stuff, that
we
the
measure
neural connection is disrupted.
We measure BDNF as a metric or a blood test for certain diseases because the levels change. But if we, in certain diseases,
Depression and so on as well.
Yeah, concussion stuff. But also degenerative brain diseases, all the neurodegenerative brain diseases, Parkinson's, Alzheimer's, MS, blah, 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 all those, BDNF levels change as well, and some more important than others. If you can increase BDNF levels, then some of those disease symptoms dissipate or become less severe. It's not a cure. In fact, they looked at BDNF and GDNF as a Parkinson's treatment. It didn't quite pan out. It helped them, but not enough. And my thoughts are the main reason was it was a single gene, and most diseases are multi-gene problems.
But you know, these days, because I'm a psychologist, with this ketamine treatment, they're trying to promote BDNF enhancement in the brain for depression and so on. So all BDNF, it makes neurotransmitters, and all of the serotonin, norepinephrine, dopamine, GDNF and BDNF products, they all are the messenger, the communication system in your brain. It's a chemical and electrical system. And so when you have a deficit of either electricity or a deficit of, let's say, serotonin, you get depressed, or norepinephrine, you get depressed. So if you have a deficit of BDNF product,
then you manifest as a certain central nervous system disease, like Parkinson's or another one. The key is to tie the deficit to a disease and then repair the deficit and then get rid of the disease. That's the idea. And so that's the research that goes on. And with BDNF, they tried that with Parkinson's, and sadly the results, initially it was thought that if we raise BDNF levels, then Parkinson's will improve, but it didn't work. And so that's just an example of research where we didn't get the answer we were hoping for.
So what are the outcomes of the reverse of cognitive decline? Because I know you guys, you do treat, but also you did back in the day some experiments like on 5 Alzheimer's or dementia or Alzheimer's patient.
Dementia,
like
all forms of
late
dementia.
Stage or
mid-stage and late stage. So with all diseases, it's easier to fix mild disease than moderate, and that's easier to fix than severe. And that's holds true with dementia or any disease, basically. Think of the brain as a city. And you have an electrical plant and a water plant and a sewage system, and you have restaurants and you have a subway system. Now, let's pretend the sewage system gets clogged up and it can't be fixed. Well, sooner or later, the restaurants close because they can't cook food. And then there's nowhere to eat. So the guys at the electrical plant, they leave town. And then the water plant too. And then you come along and you fix the sewage system, but the water system, electrical, is still offline because the plant guys have gone. In other words, the longer a disease exists, the more permanent the problems become, is the thing. With neurodegenerative diseases or central nervous system diseases, the sooner you fix them, the better. And if we can detect these diseases in the early stage, like dementia, and we can give them klotho gene therapy or HTERT or BDNF, then they get a reversal back to normal, essentially, in mild disease, and in moderate, closer. And I'm speaking generally. And in severe, it's difficult, but you can still make some improvement, but not nearly as much as you would want.
How many people so far, if you remember, you treated?
Close to 50. Yeah.
And did you receive good outcome for most of them?
All of them. There's a noticeable clinical difference. Yeah. And it goes along the lines I was saying. If they're severe, like I treated my mother, and she had advanced dementia.
All right, that's a good for people to listen, because they normally think that doctor speaks, but there are no real examples.
Right.
Now you dealt with your mother, so
yeah, my mother had advanced, and by the time I had the gene therapy to treat her, she was advanced. If I would have come 5 years earlier, she would still be alive probably and very functional. So she got a very small benefit. Like I said, if I would have treated her at moderate disease or mild disease, it would have been a totally different situation.
How much different, you think?
She'd still be alive. If she had mild disease, I could have reversed her. And she would have no dementia right now.
Because, like you explained earlier as well, with these gene therapies, it's not like a normal treatment, let's say, of Alzheimer's that need to keep repeating. It's once you place the gene inside, it keeps releasing the same needed, what do you call it? Like
it makes the product that's lacking.
Yeah.
It's what we call a cure.
Yeah.
I mean, if it works and it never comes back, that's a cure.
Sure.
And that's what gene therapy can do. I'm not saying it will do it all the time. It can do it. It has done it. It might do it again. There's a lot of variables, but yes, it's been done and it'll get better.
Many people hears about Folistatin. It was super popular, from Dave Asprey to Brian Johnson to me, and so many people did it, but not your way. It was more the plasmid.
Yeah.
What's different with yours? Because it's the muscle. You injected into the muscle, I guess, yeah?
Well, yeah, but that's not the difference. If you compare the
virus.
Yeah, you have the plasmid, then you have the AAV, or any virus, but I use AAV, and then you have CRISPR. Okay. The plasmid, like I said, is not steerable. You can't target it. And so no matter where I inject it in your body, if it gets in your bloodstream, it's just going to go wherever.
Sure.
This has not happened, I want to say, but this is a plausible scenario that could easily happen. If it goes to your heart, well, no, I'm not going to say this part hadn't happened. If it goes to your heart and increases your heart muscle very thick, we call that hypertrophic cardiomyopathy. It happens in athletes. Their heart gets so thick they can't pump blood because there's no chamber, and they collapse on the basketball court and die at age 28. That's in the news, okay? That's the danger of thickening your heart muscle too much. Now, if you're 80 and you had very thin heart muscle and the plasmid goes to it, it would be beneficial. It would make your heart thicker. And that has happened. I know a patient who got the plasmid and he benefited from it. His heart did. But that was accidental. It could have been somebody who had a thick heart muscle and they could have just as easily died, you see. So, in other words, controlling the therapy. You don't want to accidentally get lucky and help somebody. You want to intentionally.
How soon you would figure it out if it's negatively affected?
Yeah, well, it depends on how fast their muscle thickens. But my point is the plasmid therapy is not steerable. If it goes to where you don't want it to go, there's nothing you can do about it. And if it goes to somewhere where it will cause harm, you can't prevent it. Once it causes the harm's done. Is the danger. Now, it has its place in certain technologies, in certain genes, but that's the weakness is it's not steerable. The strength of the AAV virus is it's programmable. I can tell it not to go to the heart. I can tell it to go to the heart if I want it to. I can tell it to go to skeletal muscle or not. I can tell it to go to smooth muscle, which is the artery, or not. So let's say it goes to if I accidentally send it to your artery and your walls get too thick and your arteries can't carry blood, then you have a stroke. Precision and control is the important part, because if you get accidental results that you don't want, it's catastrophic.
So you only treat sarcopenia with it?
No. Sarcopenia is the term for muscle loss with age. But muscle loss from any reason, you can treat. Like say if you were born with, you're missing your right pectoralis major muscle, and you have a pectoralis minor and a major muscle. And so you have this cosmetic asymmetry, and you don't like it. I could treat the pectoralis minor muscle and make it big enough so it was symmetrical. Instead of surgically do it, it would restore the normal appearance. That's just an example. Okay. But the very important part about folistatin that nobody really talks about is the muscle part is very important for an elderly, because they fall and they'll break their hip. And if you break your hip, usually within 2 years, you're dead, because they're bedridden, they get bed sores, they get infected, they get overweight, and they never really get out of the bed often. And then they die in the bed, okay? So preventing falling is a big deal for staying alive of the elderly. Now, the other thing, the more important thing it does for everybody is it lowers your cholesterol and causes plaque resorption. The number 2 and 3 reason to die for, say, Americans is a stroke and heart attack because of plaque in the arteries.
How does it reduce the plaques?
The way folistatin works, the plaque gets slowly absorbed over time. So it undoes the plaque buildup.
Wow.
Yeah. To what degree depends on how bad it is, how much folistatin, how long you've had it in your body, what genes you have that are countering or promoting the plaque, So there's a lot of factors. But in general, folistatin, one of its main benefits, in my opinion, is metabolic, plaque resorption, increased metabolism, leaner body mass, more strength, more endurance, which means you can exercise better, and you have stronger muscles. The muscular appearance is great, but the benefits to health are huge. The problem with the plasmid is if you gave a bunch of the plasmid, you could build just as much muscle, but it's a huge dose of accidental. It could go anywhere, and who knows what's going to happen. It's a danger. So the small dose of plasmid folistatin they give now is highly unlikely to cause any problems. But let's say you wanted more folistatin.
Meaning like,
you want more muscle or more plaque resorption. If I give you more plasmid, I'm giving you a higher dose that could go to your heart.
How about the regular peptide? Like you inject subcutaneously folistatin 344, I guess?
Yeah. That has a really short half-life. If you did a comparison and you did the plasmid versus the AAV versus the injection, the most economical one that gives you the most benefits and is the safest is the virus.
Sure, I understand.
The folistatin would be far too expensive to inject to get the same results.
No, I was questioning the downsides. Like
the downside is it costs a tremendous amount of money. It's only in your system a few hours, and so you're not going to get the plaque resorption. You're not going to get the metabolic. You're going to get much less metabolic effects. Everybody has folistatin in their body. And there's another one called GDF11, which you'll read about. I have a paper coming out about that. The plasmid folistatin, the GDF11, the AV folistatin, those are all myostatin inhibitors, which are some medicines coming out. They all have a role in your muscle, and my paper covers all that. It compares all of that. And by far, the safest, most effective, biggest bang for your buck is the AAV gene therapy for folistatin, in my opinion.
How do you use the human telomerase activation?
HTERT. It's human telomerase.
Yeah.
Everybody who knows about it knows it lengthens your telomeres. But it also has a hormonal effect, too, which nobody really pays attention to. It has a dual effect. The focus has been on the telomere length because as your cells divide, the telomere shortens. It's just like a tire on your car. There's so much tread, and once you wear it down, the tire pops. Then you're dead. Well, you can put more tread on a tire. You can retread your tire. We can put more telomere length on your cell through HTERT gene therapy. Now, what's the benefit? For longevity and for health span and lifespan, it's far less important than klotho and folistatin. I think science generally agreed, because it was one of the first gene therapies, that it was going to be a miraculous thing. But in fact, nobody really pays much attention to HTERT anymore, because its real life effect is so minimal.
But you mentioned you're using for cognitive decline.
It's synergistic with klotho. If I gave you HTERT and you get an inch of benefit. If I gave you klotho, you get 2 inches of benefit. If I give them to you together, you get 8 inches of benefit. So it does have a role. I'm just saying, what I was speaking of, by itself alone, it lengthens your telomeres, but it's not a big impact. You're not going to notice anything. If we measured your age and your telomeres, we could predict you'll live longer, but we don't actually know that. But if you combine it with klotho, it's synergistic in the brain, and it helps the neurodegenerative diseases significantly.
I see that it's the performance enhancement, the muscle growth, we kind of spoke about it, but VO2 max, the EPO gene modulation. So that's interesting. So that's also true. It's not through workout, but it's through the
so the thing the folistatin does.
That's also through folistatin?
Yeah. Well, a number of the metabolic enhancers will affect that. Anything that speeds up your metabolism and allows you to exercise more will alter those parameters in a positive way.
Oh, so it's not like you do the gene therapy and
correct.
It elevates your VO2 max.
It's a consequence of more exercise and getting your body in shape. But I forgot to tell you about the other thing folistatin does. It increases your stamina for exercise. For instance, let's say you go to the gym on Monday and Thursday and every Monday and Thursday, and you exercise on Monday, and Tuesday you're sore, and Wednesday you're feeling a little better, and Thursday you go back to the gym. With folistatin, you go to the gym on Monday, you go to the gym on Tuesday, you go to the gym on Wednesday, you go to the gym on Thursday. You're not sore, your muscles are recovering.
I thought you were talking about that in your presentation in Cannes.
I was. Yeah.
You even showed your pictures.
The recovery of your muscles is the miraculous with folistatin. You can go to the gym twice a day. After you work out your whole body, within an hour, you feel normal. You go to the gym again. And that's what's most beneficial about it. I don't know I can't tell you the physiological reason, but that's the reality of the effect it can have on your muscles.
So do you think that if athletes would do it, it will be considered as doping?
Oh yeah, absolutely. Yeah. And
would it be
detectable? Yeah.
Yeah.
Well, yes and no. Can I figure out a way to do it so it's not detectable?
I'm giving weird ideas to people.
Yeah. There's ways you could do it that it's not detectable right now, and there's ways you could do it that it's obviously going to be detectable. So, yeah.
I'm sure I'm not the only person who's thinking that way.
Right.
But so all these metabolic efficiencies, injury preventions and stuff, you're mostly using the metabolic genes.
Yeah. The PGC1 alpha, FGF21, and the klotho. Even the HTERT.
What was PGC1 alpha doing?
PGC1 alpha is what we call the master of mitochondria.
All right.
It makes more mitochondria.
Wow.
It makes mitochondria more efficient, the less pollution, and it makes them their ATP output skyrocket. So
I think that's as important as klotho in a way.
It's super important. And FGF21 does very similar. Same path, but it does slightly different. But they're both major metabolic. Those are the two that fix type 2 diabetes, and obesity. Those 2 genes are 2 of the major players of the 5 that are in that cocktail. And they're so important, I don't even remember the other 3 right now, to be honest with you.
And there are the genetic diseases and rare disease you're mentioning over here.
Yes. So I'll tell you a story. I might get a phone call tomorrow from somebody in Saudi Arabia, and they say, my child was just diagnosed with a genetic abnormality. And I'll say, okay, well, what disease do they have? They say, I don't know. We don't know. It's the first time it's ever discovered. It doesn't have a name yet. In other words, medical science is discovering things very rapidly right now genetically that we didn't. They're syndromes that we didn't know they were syndromes. We just thought it was unique to that person. But it turns out that we're finding genetic diseases that we can now pair with a symptom with something on the test. And then next thing you know, it has a name after the doctor discovered it. But they're coming so fast, they don't even have names right now. And if they're a single gene problem, you can correct that single gene problem in theory and in reality. It's a quandary. What do you do? If you called me up and said, my child has...
Actually, somebody, let me tell you, I received an email, and hopefully that person would listen to me. I have his email. I received an email 2 weeks ago. This gentleman who lives in Germany, who is watching my podcast, Turkish guy, says that, I don't know what's wrong with my daughter. She has endless weird stuff is happening. I want to give one example is suddenly she lost the power on her legs with no reason. Nobody was able to figure out what's happening, and slowly it came back. But it seems like this poor girl keep having different thing. And his email was saying like, do you know anyone that we can go to? But it seems like at some point I need to go to a genetic expert or some gene centers to figure out what's happening. So that's either genetic or immunological. It's probably a combination of both. It's probably a form of a genetic autoimmune disorder, that is likely genetically based. That's what it sounds like. That's actually becoming more and more common because of the industrialization of our world, all the chemicals and things that interact with that's epigenetics, things that interact with our genes, that turn genes on and off that never existed, and they turn genes on that you don't want turned on, and then they cause all sorts of problems, and vice versa. So what I was saying was something along the lines, if you called me up and said, my daughter, a 4-month-old daughter, was just diagnosed with this single genetic abnormality, and as a consequence, she's not going to be able to live by herself for the rest of her life. We're going to have to put her in a nursing home. Can you help? And I look at the gene, and I can build the gene in my lab. I can put it in the virus, and I can give it to her. And that would cure her, okay? But it's never been done because she's one of 12 people on the planet that have this disease. This is a real story. Oh. Yeah. So do I do it? If I do it, all sorts of scientists will say, oh, you're experimenting on humans. That's horrible, horrible. If I don't do it, she's going to go.
She lives in a nursing home the rest of her life. That's the quandary we're in right now. In my opinion, it should be the person's decision, the parents or the patient, because in the United States, they've made it legal in some states to commit suicide. Yeah. If you're going to allow somebody to elect to kill themselves, why would you allowing them to elect to have a experimental therapy? You see what I'm saying? Yeah. And so it's a big debate.
Do you think with the new government it's going to be shifting a little bit?
Because I don't know, but it's not necessarily the government. It's actually the scientists that I get flack from.
Oh yeah.
It's other doctors that are critical of this, but they're not sitting in my seat having to deal with it. They're living their happy life and unaware of this tragedy.
Yeah. You're right. Dr. Sewell, so you're very much reached out from all over the world, from big countries for your help. Would you want to share a little bit?
Yeah, that's the exciting thing. So, and not the United States. I won't say much about the United States other than it's going backwards, including the medical system, and hopefully it'll turn around. But the rest of the world seems to have wised up and realized that that it's smarter to cure disease than treat it forever. economically mainly. And so I have been fortunate enough through acquaintances and friends and connections and accidental to meet several governments that want to take their citizens and provide them with a cure for a disease that we could do now. And so these are genetic diseases that are common, that are fixable, but we need to do the clinical trial. We need to build it and do the clinical trial. So I actually have a couple of countries that the governments are working with me. They've asked me to come in, build the gene therapy at the university, do a clinical trial, all above board. I could never do it in the United States. That for whatever reason, it moves so slow there. The rest of the world is moving quite rapidly, and these are progressive countries that to me are very wise.
Would you like to share the patient's journey for one of the things that we discussed here, whether klotho or PGC1 alpha or anything else or combination? What is the journey if they would like to have either for anti-aging or for curing any of these diseases?
Sure.
They come to your, like they say, knock, knock, here I am, I have this. Then you have a very specific procedure that you request.
It's hardcore medicine. You can't knock on the door and say, give me klotho. I'm not going to give it to you. You don't get to ask for it. You have to need it. Okay. Just like you can't go to knock on a surgeon's door and say, take my appendix out just in case for the future. I don't want to have a problem in the future. Cut it out now. He's going to say, no way. That's crazy. So that's my world too. So if you come to me and you say, I've been diagnosed with this problem, and I look at all your records, and we'll probably usually have to do some additional testing. And we treat it just like a regular medical disease, cancer or appendicitis or whatever. If you come to me because you want to live longer or better, health span or lifespan, then I have to do an analysis. I do a DNA analysis. I do a whole exome sequencing, sometimes a whole genome sequencing, an RNA sequencing. And these are blood tests that I can tell what genes you have and how well they're functioning or malfunctioning or not functioning at all. And if they're not functioning, can I fix them? So I gather a bunch of specific scientific information on you personally, your situation, and then I discuss it with you if we fix this, this would be the benefit. If we address this, this would be the benefit. Of course, there's a physical exam, there's other lab, there's a discussion about your life and what you want to achieve. And then after all that, I say, here's what I'll offer you. And you can A, B, and C, or you can have all this, but here's what I recommend. The patient gets to choose. And they get to choose how to change their life for the better based on scientific data.
And then once it's decided, okay, how do they go? Like how many days it takes? Do they need to go a typical specific protocol in order to receive the virus?
Yes. So if they elect to have a gene therapy, then there's a series of events that happen. One is I start them on some certain medications to prep them. But I start building the gene therapy, and it takes me 8 to 10 weeks to build it in the lab. If it's a personalized one, if it's Folistatin, I have to pull it off the shelf, and you could get it next week. But if it's a congenital genetic defect or cancer, then I have to build it, and that takes time. 8 to 12 weeks is the average time. It's it's more complicated than going to the moon and back.
How about you said the medication and stuff? So it takes for the person like a couple of days, couple of weeks.
Oh yeah. So once I do the gene therapy, I can measure the effects within a week. The genes.
What I say, like for the virus, so do you do through the IV?
Yeah, the longevities are largely IV. There's for the brain, we could be intraarterial, intranasal, or intrathecal. But IV is the vast majority, intravenous.
And through intravenous, you can send it to the brain if you want.
I can target it to the brain. But if I want to target it better to the brain, then intranasal is better. And
like spray or
no, it's an injection because well, there's you get sedated and pain medication, so we don't torture you. So all of the gene therapies I deliver the gene therapies based on the organ and what we're treating. So let's say it was your kidney. I would go in the artery to the kidney and inject the gene therapy just in the kidney artery because it doesn't need to be anywhere else. Otherwise, it's wasted, you know. If it's your liver, I'd go in the hepatic artery, or I'd inject it straight into the liver from the outside with the ultrasound or CT. If it's your whole body that needs something, then you get it intravenously, and it goes all over.
And it's one day,
it's like 30 minutes or an hour.
That's it. So it's not multiple days. It's
one treatment. One treatment.
And typically it's around 2 decades, you say, lasts?
2 decades we know of, probably longer. The exceptions would be if you had an abnormal immune system that was overly aggressive, or you had a weak immune system, it would last longer. So there are factors, but the average person, we can say on average 20 years, 15, 20 years is what the data shows now for people who've already had gene therapies.
Is there a chance that it's not working? Or is there a chance that you get sick? And because I think I heard from Liz something like, there might be once in a while that the person gets sick and feverish.
If you catch a virus, you get sick. You get sniffles and cough or fever. That's your immune system reacting to the virus. The virus is not actually doing that. Your immune system is fighting the virus. That's what causes fever and all this stuff. I can suppress those symptoms so you don't experience that with medication. I have a very detailed way to give the gene therapy so it's safest and
it stays.
It's effective, has the greatest chance to work, it has the greatest chance of being completely safe, it has the smallest chance of having an adverse reaction, and the biggest chance to lasting the longest time. And that's a number of things involved in that. I have to address certain parts of the immune system, how I deliver it, how I build the virus, because it's not just the virus and the gene. In that, there's a promoter, there's an enhancer, there's an immunomodulator, there's a targeting peptide. All these other components that are incorporated in what I call designing the gene therapy.
I see.
I mean, I could build a car with one seat and no doors and no roof, but a more sophisticated car would have a navigation system and seats and doors.
Where is your actual location?
I have several locations, 2 in Mexico, Belgrade, Serbia, Dubai is coming online. Probably by the first of the year, we'll have 6 or 7 sites in Asia. Of course, several sites in Europe too. And some of those are governments, some of those are in the EU, but they're government approved because we're doing projects there.
The reason actually I didn't meet you, but I watched you at Longevity Docs, but the only longevity clinics that there is in Turkey, in Istanbul, Only Health. My dear friend Murat called me yesterday and he said, I have a surprise for you, and you came here as a guest, and there's a great news that they're going to be opening a secondary clinic in Cabo, Mexico.
That's exactly right.
And you're going to be helping them to build their gene therapy protocol.
Exactly. I'm an advisor for Only Health, and they're expanding to other countries, and they're coming to Cabo, and they're going to be next door to me.
That's wonderful because, for most people in Turkey who watches my program, one, they're very interested. 2, they trust the people that comes to my show. 3, they don't know where to go. And Only Health is one of the only places that I truly, from the bottom of my heart, suggest them to go instead of wandering in the middle of wherever, because it's very difficult to find these legitimate places.
You have to have a personal recommendation for it to be safe, pretty much.
Probably they're going to be having patients who, whether they have some diseases or they want to have a better health, and they're going to come.
That's where the collaboration comes in, because Only Health is focused on health, but my heavy part is cancer, and so they obviously are going to get cancer patients, and we want them to have the best of all possibilities. And as I expand into Asia, I'm sure Only Health will expand into Asia too.
Before we're closing, let's talk a little bit about your new gene therapy for addiction. Because it's my specialty, and people who are going to be listening, maybe we can get some volunteers to get into the trials. Can you explain what it is?
Yeah, so at the heart of opiate and alcohol addiction is dopamine. And the therapies for those addictions have been aimed at increasing dopamine. And that's difficult because in pill form, it's not well tolerated. It makes you nauseated and side effects, and it's not absorbed well, and not much of it gets to the area in the brain that's needed. So I have a gene therapy that has been tested in humans, and it was used for Parkinson's disease, and I've adapted it for addiction. And I'm looking for 20 patients to treat for free. They'll get the treatment for free. I'll have to do lab and psychiatric exams, treat them, follow them for 6 months, and do lab and psychiatric exams. And it's going to be a clinical trial. And I want to document the benefit. My estimation, reliable, I think, is that it will reduce cravings for opiates and alcohol by 90%. So there's two parts of addiction, as you know. There's the psychological and the physical. And this should, in the best case scenario, and probably most 80%, but in the best, 90% of the people their physical craving would disappear and never come back. So all we'd have to deal with is their psychological issue.
It's a little bit like what Suboxone and Vivitrol does.
Yes, exactly. Except it's a one-time treatment.
Yeah, but the other ones are like for the cravings.
Yeah, exactly. Yeah. And you're free. Who wants to be chained to a pill every day for the rest of your life? And
but also like you said, it's not going to change their psychology, and it's a weird thing, they think that it's going to fix their problems.
No, you still have to do that work.
But it doesn't need to be someone who's in active addiction, which you need for the trial. But, many addicts, I spoke with also Dr. Anna Lemke about that, the dopamine addiction and dopamine need of humans. Some people have less dopamine and so many dopamine receptors. It may help to these people who are not enjoying life as much. Exactly.
No, they don't have to be an active addiction. They have to be suffering with cravings to change their life through alcohol or opiates, change their feelings. And the therapy should take away the desire to alter themselves with alcohol or opiates. Because
they will less cravings and they will enjoy life without the thing because, instead of...
They will have what they need inside. Instead of searching outside and using alcohol or opiates to change the inside, they won't have that need because it will be changed by the gene therapy permanently.
Do you have any message to people who watches us? Because you don't have many podcasts out there. Hopefully this would be going viral.
The message is... it's it's several messages.
Please
One is the therapy will come down. The cost will come down. And number two is this is how we will treat people in the future. Within a few years, no longer, when you go to the doctor and they say you have diabetes, no longer will it be you need to take this the rest of your life. It will be we're going to cure you with this therapy. We're scheduling you for boom. And then you're done the rest of your life. The biggest message is gene therapy goes to the source of disease. So we're no longer managing disease. We're actually eradicating it from that person's life forever. We will be able to cure a person of a disease rather than have to manage it. So like, for instance, I have to take 4 or 5 pills every day, high blood pressure, blah, blah, blah. If a nuclear bomb went off and there are no pharmacies, I'd be a dead man because I won't have my high blood pressure medicine. If I could fix my high blood pressure medicine with gene therapy, and I wouldn't need that pill, I would be free. I wouldn't be chained to the pill. I have to, no matter where I go, I got to make sure I have my medicine. That's not a way I want to live. I want to be cured of that. And that we're on the threshold of that. We're literally, for most things.
And it's safe?
Yes. Yeah. Well, yeah. I mean, like everything is dangerous and safe. I mean, automobiles, we accept those and they kill more people. You know what I mean? So the question of safety is always contextual. In the context of done correctly, gene therapy is safe.
Because maybe we forgot to say before we close, let's say that because CRISPR is different. That's why. Can you say how CRISPR works and your worry is to carry it through the generations?
Yeah, CRISPR is physical change. It snips, it cuts out part of your gene and puts a gene in, or it cuts it out and doesn't put one in. So it alters your genes. The one I do doesn't alter your genes. It adds an additional gene, a helper gene. It doesn't change your DNA. It adds a booster that sits nearby. Whereas CRISPR actually changes the DNA in all your cells. So if it changes it in a bad way, you're stuck with it. You can't, well, if it changes in a bad way, then you have to use CRISPR to unchange it. And then that could go wrong too. Simply because we just don't know that much about CRISPR. CRISPR is not inherently dangerous. We don't know enough on how to use it correctly. It goes back to the same thing. Gene therapy done correctly is safe. CRISPR, we don't know how to do it safely. So it's yet. So we need more science, study, data, time.
And your website is?
TripleHelixScience.com.
Okay, we're going to add everything on the show notes. Thank you very much for being
Absolutely.
at my
Thank
show,
you.
and it was super informative.
Thank you.